Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about tracheostomy tubes. In my previous classes, I have discussed how to do tracheostomy, what are the indications, the contraindications, and what are the complications of tracheostomy. Today we'll learn everything about a tracheostomy tube. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. Now, before we get into knowing the tracheostomy tube, let's first know what are some criteria that makes it an ideal tracheostomy tube. First of all, is that it should be able to maintain a safe patent airway without kinking or collapsing. Second, it should be able to allow effective ventilation. Third, it should minimize the trauma caused to the trachea. If you do not use the correct diameter and length of the tube for the particular patient, then the tube may end up pressing excessively on the tracheal wall, and this can lead to multiple complications like tracheomalacia, tracheal stenosis, etc., and even the development of tracheoesophageal fistula. So, our tracheostomy tube should be of the right size so that it does not cause damage to the tracheal wall. Next, it should be easy to insert, change, secure, and even clean. And ideal tracheostomy tube should permit proper airway care, suctioning, and management of the secretions. It should be non toxic and cause very minimal tissue reactivity, and it should be easily connected to a ventilator. These are all certain criteria that makes a tube a ideal tracheostomy tube. Now let's try to know what are the parts of a tracheostomy tube. Now, if we look at the image over here, this first image that we are seeing, this is a metallic tube that we are seeing over here. This is a Chevalier-Jackson tube. Now, the first part that we are seeing, this is the outer cannula. The second one is the inner cannula, and the third one is the obturator. So, first, let's talk about the outer cannula. Now, this outer cannula forms the main body of the tube that we are passing into the trachea. And the size of this outer tube, outer cannula, only suggests the inner diameter of this outer cannula suggests the size of the tracheostomy tube. Then we have the inner cannula. Now, inner cannula is not present in every tube, but whenever it is present, we can see this is the second image over here. This is the inner cannula. This is a removable tube which fits within the outer cannula itself. And if you look at it, the length of it is more than that of the outer cannula. What is the purpose of this tube? The purpose of this tube is to prevent the collection of secretion at the end of outer cannula. So, you have to repeatedly keep removing this inner tube, or sometimes even you have to replace it so as to clear out all these secretions and maintain a clear airway. Now, this inner cannula, it has different types. It can be a reusable one, it can be a disposable one, it can have fenestrations in it. We'll talk about it in some time, and it can also be plain. Sometimes even the inner cannula can be colored so that it can be easily identified. For example, in Potex tubes. So this was about the inner cannula. Now let's look at the other parts. Now, other than the outer and inner cannula, we also have something which is the cuff. Now, if you look at the image over here, this is what the cuff looks like. Now, cuff is basically a balloon which is placed at the distal end of the tube. And when you inflate this cuff with air, it helps to provide a seal between the tube and the tracheal wall. So, when you're inserting the tracheostomy tube into the trachea, the cuff should be deflated. And when after you have inserted, then you should inflate the cuff so as to protect the patient from aspiration and allow positive pressure ventilation. So, this is the purpose of having a cuff. And we'll talk about more about different types of cuffs that can be present and what is the pressure that should be maintained inside this cuff in a little bit. So, our fourth part is something which is known as the pilot balloon. Now, if you look at the image over here, this is the pilot balloon. So, this is basically an external balloon which is connected to the inflation line by the internal cuff. And when this cuff gets inflated, the pilot balloon is also inflated, and vice versa. So it basically reflects the inflation of the cuff. So that is about the pilot balloon. Next part is the neck plate or the flange. Now, if you look in the image here, this is the neck plate. This is what is helping in supporting the whole tube structure and preventing its descent into the trachea. This is what is giving support to the tracheostomy tube. And if you see these tiny holes over here, these holes are through which we pass either a tape, tie, or suture to secure the tracheostomy tube around the neck of the patient. So, this part is very important, and this neck plate is where the tube code, the size, or the type is written. If you look at the image here, there are certain things written over here. This is where we find the tube code, size, or type. And the neck plates, there is some difference in neck plate between a pediatric tube and an adult tube. In an adult tube, the neck plates are straight, like we just saw. But in case of a pediatric tube, they have a slightly angled neck plate, and this is given so that it can accommodate for the short neck of the patient. We also have something which is known as adjustable flange tube. We'll talk about it in some time. These are basically tubes that allow variable tube length to be used. So you can adjust the flange to adjust the length of the tube. This is especially useful for patients who have a large neck or who have an increased pretracheal space. So these are some parts. Next, moving on to obturator. I showed you in an earlier image, this is what an obturator looks like. This is also known as an introducer. What is the purpose of this obturator? This obturator is usually placed inside the outer cannula of the tube during the time you are inserting the tube. That is the sole purpose of it. Now, what does it do? How is it helping? You can see that it has a very bevel rounded tipped shaft, right? This is very atraumatic. So, when you're putting in the obturator in your tracheostomy tube while you're introducing the tube, it will provide a very atraumatic experience. It will not end up injuring any of the structures nearby. So, basically, it helps in reducing the trauma of tube insertion. And once you have inserted the tracheostomy tube, you remove the obturator immediately to allow the entry of air and exit of air, and then you assess whether the tube has been correctly placed or not. So, this is the obturator. Next, we have sometimes we even have fenestrations on the tube. If you look at the image here, this we can see multiple fenestrations. There can be a single fenestration or there can be multiple fenestrations on the superior curvature of the shaft. This is the superior curvature of the shaft, and the purpose of the fenestration is to allow airflow through these holes that are present so that there is some airflow around the tube happening, and as a result, this will allow the patient to speak and cough more effectively. So, if we want the patient to be able to speak, in that case, the fenestrated tubes are preferred. And lastly, there's another structure that comes is which is a 15 adapter. Now, this is an adapter that you usually fix to the tube over here, and this is responsible for allowing the connection to ventilation equipment, since one of the main indications of tracheostomy tube is to give positive pressure ventilation. So these are all the parts of a tracheostomy tube. We have the outer tube, the inner tube, cuff, pilot balloon, flange or the neck plate, which helps in securing the tube, obturator, fenestrations, and a 15 adapter. There can be even some more accessories to the tube in certain cases. Let's talk about that. The first accessory is having a speaking valve. What is the speaking valve and what is its purpose? As you can already say from the name itself, it's for phonation. So, this is usually a one way valve which is placed at the distal end of the tube so as to facilitate the entry of air of the upper airway. And this is used for phonation. And because this is a one way valve, what it does is it allows the air to be inspired. But when you're trying to, when you're on expiration, the valve gets closed because it is a one-way valve, and thus it will allow the air to pass into the upper airway and help in phonation. But it is important to remember that we can only attach a speaking valve to an uncuffed tracheostomy tube. It cannot be used in cuffed tubes. Second accessory is having an occlusion cap. Now, this occlusion cap is basically a piece of plastic that is placed at the distal end of the tube, and this is for blocking the entry of air through the tracheostomy tube. This is something that we use during decannulation. If you want to learn more about decannulation, you can check out my video on decannulation. I have spoken way more in details over there. So these are all the tube parts that we need to know. Now, why do we need a tracheostomy tube? What are the functions of the tracheostomy tube? So, its first function, the most important one, is that it allows prolonged positive pressure ventilation. Second, it protects the patient from aspiration. Third, it helps in bypassing an upper airway obstruction. And lastly, it allows access to aspirate the secretions. So, these are the functions of the tracheostomy tube. Next, let's talk about what are the materials that we can use for a tracheostomy tube. Now, there are various types of material used. For example, the most common one used is polyvinyl chloride. Now, polyvinyl chloride is usually used to make disposable tracheostomy tubes that are only needed for short term use. The advantages of polyvinyl chloride is that it's very cost effective, has good flexibility, and it is also thermosensitive and adjusts to body temperature. But the disadvantage of this tube is that it is very prone to retention of bacteria, thereby increasing the chances of infection. So therefore, we should only use it for a short-term purpose. If you have to use it for a long-term purpose, in that case, we would prefer to use metallic tubes over this. Second type of material is silicone. Now, silicone, what it does is it reduces the adherence of secretions, and hence it decreases the chance of bacterial retention, as a result of which you will have reduced chances of infection, and these tubes can be easily sterilized. Therefore, we prefer silicone tubes, especially in the pediatric age group. Then we have something known as the siliconized polyvinyl chloride. Again, this is something which is thermosensitive and it adjusts to body temperature. Next, we have silver. Some tubes, like for example, the Chevalier Jackson metallic tube, is made up of German silver. So, this silver is usually 92.8% silver and there is copper. Now, these tubes can get fractured on prolonged use. Therefore, you should make sure that you're also changing them frequently as and when required. Tracheostomy tube can also be made of stainless steel or silastic. Silastic is silicon rubber, but it lacks rigidity. So these are all the different materials that you can use when making a tracheostomy tube. For short-term purposes, polyvinyl chloride is really good. For pediatric age group, silicone tubes are good. And if you're using a tube for a very long term, in that case, we'll prefer a metallic tube. Next, let's look at the different types of tracheostomy tubes. Now, there are a lot of variety of tracheostomy tubes. Like, for example, it can be metallic or non-metallic. It can be cuffed or uncuffed. It can be a single lumen or a double lumen tube. It can be fenestrated or non-fenestrated. It can have an extended length or an adjustable flange tube. And then there are neonatal and pediatric tubes. Now, I'll discuss each one of this. Let's get started with metallic tube. Now, metallic tubes are usually made of stainless steel or German silver. They usually have, if you look at the image, these are the two common metallic tubes that we know. The first is Chevalier Jackson's metallic tracheostomy tube, and the second one is Fuller's biflanged tracheostomy tube. So you can see that they usually have an outer tube and an inner tube. This reduces the chance of blockage of the tube because you can easily take out the inner tube and clear out all the secretions and put it back. And metallic tubes do not have a cuff, so that is something to keep in mind. Therefore, metallic tubes are not used when you are just performing a tracheostomy in the patient and you're inserting the tube. The first tube should not be a cuffless tube. So in them, we will not prefer to use a metallic tube. And metallic tubes are also not usable if a patient is to be taken up for MRI because this is made of metal. So this is contraindicated. Even if a patient needs to be taken for radiotherapy, in these cases we will not use metallic tubes. Metallic tubes are very useful for long term tracheostomy. Another disadvantage of metallic tube is that it cannot be connected to the ventilator. So, in all of these situations, and in case of a initial tracheostomy, in all of these cases, we will not prefer to use the metallic tube. So, if not metallic, we also have non-metallic tube. For example, we have the Potex tube, which is the most common tracheostomy tube to be used. This right image is the Potex tube. This one is the Shiley's tube. So, there's multiple other such non-metallic tubes. Now, this Potex tube is the most common one that we use. And if you see, the Potex tube does not have an inner tube. So, therefore, these tubes have more chances of getting blocked. Therefore, because it has more chances of getting blocked, we should keep changing it from time to time. And this is also meant for short term use only. Therefore, these tubes are also very cost effective because they only last a short time as well. And Potex tube, as you can see, it has a cuff in it, and this cuff is useful for giving positive pressure ventilation, for preventing aspiration, and to make the tube self retaining. This can be used in patients who do not tolerate metallic tubes as well. And so that's more or less about the Potex tube, which is a non metallic tube. So we have learned the first type, which is metallic and non metallic type. Now, moving on to the second type, which is uncuffed or cuffed tubes. First, let's talk about the uncuffed tubes. So, uncuffed tubes, as you can see from the name itself, if we look at the first image over here, this is an uncuffed tube. So, you can see there is no cuff present at the distal end of the tube. Now, what are the indications of using uncuffed tube? Indications of uncuffed tube would be when we do not need mechanical ventilation. I mentioned earlier, whenever you're putting the a patient on mechanical ventilation, it is necessary that you use cuffed tubes in these cases. Second indication of uncuffed tube, if there is no risk of aspiration, in a pediatric and neonatal patients. Now, pediatric and neonatal patients, their trachea is still developing. So, we prefer not to use an cuff tube over here so as to minimize the damage caused to the trachea. Because if you end up using cuff tube, it can lead to the development of tracheomalacia or tracheal stenosis or tracheoesophageal fistula. Next indication is we use an uncuffed tube during the time of weaning off the patient or decannulation. And lastly, we also use them in long term cases who are in stable condition. So these are the indications of using an uncuffed tube. Now, there are also some contraindications to using uncuffed tube, which will be number one is if the patient is dependent on positive pressure ventilation, if the patient has a significant risk of aspiration, and thirdly, if there is a newly formed tracheostomy. In that case, we would prefer to use a cuffed tracheostomy tube. So that's about the uncuffed tubes. Next is cuffed tubes. Now, there's a lot to know about here. So, cuffed tube is usually the first tube that we insert during the time of tracheostomy. This tube helps you in providing a safe airway until a patient gets weaned from the ventilator, the wound site gets stabilized, and the patient can control their own secretions. You can deflate and inflate the cuff as and when needed according to the need of the patient. Now, these cuffs that are present are usually barrel shaped cuff, which has a high volume but low pressure. Now, what is the importance of having high volume and low pressure? This is responsible for allowing a wider distribution of pressure on the tracheal wall, and thereby it reduces the incidence of tracheal ulceration or tracheal stenosis at the site of the cuff. So that's how the cuff functions. Now, how much pressure should be put inside the cuff? That's also something that we need to understand. So, how do we measure the cuff pressure? We can use a cuff pressure manometer, and this can be used to measure the cuff pressure being exerted on the tracheal wall. Now, there's some ideal cuff pressure that we need to be aware about, and this pressure is 15 to 25 centimeter of water or 10 to 18 mm Hg. Now, this also has a logic over here. So, if we look at the normal tracheal capillary pressure, you'll see that it is about 20 to 30 mm Hg. So, we should not cross a certain number over here because then it will lead to total obliteration of this tracheal capillary flow. What is the number you should not exceed? The cuff pressure should never exceed 37 mm Hg. This is very important to remember. We need to know what is the ideal cuff pressure and what is the cuff pressure that we should never exceed. So, if you end up exceeding the recommended limit for a prolonged period of time, that will lead to a lot of complications because of the continued cuff overinflation, like tracheal stenosis, tracheomalacia, and tracheoesophageal fistula. Now, if we are seeing that we are needing to put excess pressure inside the cuff so as to maintain the seal in the patient, in that case, we should be aware that probably the patient needs a tube of larger diameter, and this tube is not serving the purpose anymore. Next, let's talk about what are the indications and contraindications of cuffed tubes. So, indications would be when there is a need for positive pressure ventilation, when there's risk of aspiration, when the patient is unstable, and in a newly formed stoma. And contraindications, most important to remember, is young children and neonates because they still have a developing trachea going on. So you don't want to injure the trachea anyhow. And second contraindication is if there is any kind of tracheal injury, tracheomalacia, or any history of recent tracheal surgery, will avoid the usage of cuffed tubes in these patients because it will end up in causing more damage. Now, I was mentioning earlier that there are many variations of specialized cuff tubes. Let's learn each one of them and what is the purpose of each one of them. So, first one is a foam cuff. Now, foam cuff tube is one which has the capacity to spontaneously inflate on insertion and then conforming to the patient's trachea. So, what happens here is it is constantly inflated. Thereby, there is no risk of over inflating the cuff. Now, what is the mechanism here? So, this is basically a silicone puff. If we look at the image, this is what it looks like. This is a foam cuff. So, this is a silicone cuff which has a plastic foam inside. Now, before you're inserting the tracheostomy tube, what we need to do is first we'll evacuate out the air from the cuff with the help of a syringe. Why are we doing this? This is done so that the atmospheric pressure will be able to compress this plastic foam which is inside so that the tube becomes easy to insert. Now, once the air has been evacuated, then we insert the tube inside, and when the cuff, we know that the cuff has reached the trachea, the cuff deflating tube is left open. Now, this will allow the air pressure to equilibrate. And once we reach the equilibration, the compressed foam will expand because of its elasticity and thereby creating a seal in the trachea. So, this is basically a spontaneously inflating cuff tube. So, that is the specialty of using foam cuff. Second specialty is a tied to shaft cuff. Now, these tubes, if you look at the image over here, this is a tied to shaft cuff. They have a cuff itself, but when this cuff gets deflated, it looks like almost an uncuffed tube. So you can see here that this looks almost like as if this is an uncuffed tube. What is the advantage of this? This allows a less traumatic tube insertion and withdrawal as compared to a normal uncuffed tube. So that is the advantage of using a tied to shaft cuff. Third specialization is having a suction port. Now, if you look here in the image, you can see that this is a suction port attached. So, the suction port above the cuff, it allows regular removal of secretions, thereby reducing the risk of aspiration and associated risk of infection. So, that's about a suction port which will help you in reducing the aspiration risk. Next specialization is we have double cuff. If you look at the image on the left side, we can see that there are double cuffs. Now, what is the advantage of having double cuff over here? Because here double cuff can use the alternation of cuff inflation so as to allow pressure relief on a high risk tracheal mucosa. So you can alternately inflate one of the cuffs, and this will help in relieving the pressure on a risky tracheal mucosa. Next, there are two others. One is the Lanz cuff. Now, Lanz cuff or the Lanz system, what it does is it automatically controls and limits the cuff pressure during the entire duration of the tube in position. And lastly is the parachute cuff. Parachute cuff is partly open distally and it distends when the intratracheal pressure is higher than the pressure above the cuff. This basically functions like a backflow valve. So these are all the specialized cuff systems that we have. What are the indications, the contraindications of using a cuff tube, and what is the ideal cuff pressure that we should maintain in case of a cuffed tracheostomy tube. Moving on to the next type of tracheostomy tube, which is a single lumen and a double lumen tube. Now, first talking about single lumen tube, as the name suggests, it only has one cannula which stays in situ throughout its use. Usually, single lumen tubes are made of silicon or a mixture of silicon and PVC because these have an increased resistance to the secretions adhering to the tube. Since we do not have a inner cannula in this case to remove and clear out the secretions, therefore the usage of silicon is very useful over here because this material does not allow the secretions to adhere to the tube, and also it reduces the bacterial adherence to the tube. Next is double lumen tube. Now, in double lumen tube, we have two cannulas, the outer and inner cannula. And the inner cannula's importance is that it helps us in cleaning the tube. So, if the patient is having a lot of secretions, the secretions collect inside the inner tube, and we can take out the inner tube from time to time, clean it, and put it back. This advantage is that it reduces the risk of the tube getting blocked, and also it reduces the frequency of tube changes, because a case of tube change also causes some amount of discomfort to the patient and even causes trauma to the stoma side. So if we can reduce the frequency, this would be the way to go. So this was about single lumen and double lumen tube. Then we have fenestrated tubes. Now fenestrated tubes, as I showed earlier, they can either have a single fenestration. This image over here shows multiple holes over here, but you can also have a single hole. And this hole is usually placed on this outer curvature of the tube. And this allows, the purpose of this hole is to allow the airflow upward around the tube so that it can enable phonation. So when you want the patient to speak, in that case, fenestrated tubes are required. Next is the adjustable flange tubes. Now, what is the adjustable flange tubes? So the usual standard tubes, they have a specific length, right? So these standard tubes, in certain cases, they are not safe for the patient. These could be cases where there is an increased tracheocutaneous layer, or if the patient has an enlarged thyroid gland. In these patients, the standard length of the tube may not be able to enter the trachea, or even if it does enter the trachea, it can enter it at an angle that will make ventilation and secretion clearance very difficult. In these cases, using an adjustable flange tube, this is what it looks like. We can adjust this flange over here and determine the length of the tube. These would be better. But it's important to know that these tubes usually lack an inner tube, and therefore they lead to a lot of collection of secretion which can end up blocking the tube. Therefore, you should do regular suctioning of these tubes. So, this is about the adjustable flange tubes, also known as extended length tubes. Lastly, are the neonatal or the pediatric tubes. These tubes are very different from adult tubes. They do not have an inner cannula because of the small size. And to avoid the buildup of secretions inside the tube, we should change the tube every week. And I had mentioned earlier, we prefer to use silicone tubes because the silicone tubes allows the mucus to pass more effectively through the tube, and it reduces the adherence of secretions and bacteria to the tube surface. And because the neonates and pediatric age group has a developing tracheal tissue, it's very delicate and it has also a narrow cricoid ring. We will not prefer to use cuffed tube in them. Uncuffed tubes are preferred in case of neonates and pediatric age group. So that finishes our discussion on all the different types of tracheostomy tubes. Lastly, a little bit about tube selection, about the size of the tube. So, two things we need to keep in mind. One is the outer diameter of the tube, and second is length of the tube. Now, we should not look at the manufacturer size usually given, because and the manufacturers usually do not follow a certain standardized method over here. So, a Portex 8 mm tube may not be the same as a metallic 8 mm tube. So, it's more important to look at two parameters, which is the outer diameter of the tube and the length of the tube. Now, outer diameter of the tube should not be more than two-thirds to three-fourths of the tracheal lumen. This number is usually 10 millimeter in females and 11 millimeter in males. Secondly, is the length of the tube. Now, length of the tube, if we this is the trachea and this is the carinal region, we have to remember the tube that is being placed. It should not be more it should not come at the level of the carina. There should be at least a distance of 1.5 to 2 centimeter from the carina. That's how the length of the tube is decided. So for an adult, this length varies between 60 to 90 millimeter. For pediatric age group, 39 to 45 millimeter, and for neonates, 30 to 35 millimeter. Lastly, for mini tracheostomy, we usually use a 16 Fg single lumen PVC tube. So that's all about tracheostomy tubes. If you have any further question, please note them down in the comment section and I'll get back to you. Thank you.